All right. Good morning for everyone that's out there, everyone that's listening to the recorded lecture. This morning, we're going to talk about oral complications of radiation therapy to the head and neck, which all of us as otolaryngologists, not just oncologists, are going to see. And as we know, the profile of head and neck cancer has shifted in recent decades, reflecting an increasing proportion of human papillomavirus and decreasing tobacco use. This has resulted in an increase in younger survivors with a more favorable prognosis and the potential to live decades with the sequelae of treatment. Head and neck statistics indicate that the overall incidence is stable over the past 30 years, but that the proportion of new diagnoses among the 45 to 54-year-old age group has increased from 16% in the 1980s to nearly 25% in the early 2000s. At the same time, there's been a gradual trend toward increased survival in all head and neck cancer patients. Between 1992 and 2006, overall 5-year survival went from 54.7% to 66%, compared to an increase of just 2% over the previous 10 years. A few winters ago, in Philadelphia, a newspaper published an article that I think really illustrates this demographic shift. The police were called to a house to intervene on a popular Philly habit of shoveling out a parking spot and saving it with a folding chair or an orange cone, or in this case, this sign that reads, "This spot was shoveled out by a cancer patient for him and his wife." And this is the cancer patient. This guy's in his 40s. He's got a 2-year-old kid and a pregnant wife, and is more along the lines of the changing face of head and neck cancer. But at the same time, it's well recognized that the better survival outcomes from contemporary treatment regimens come at the cost of significant debilitating toxicity in a large proportion of patients. Radiation is the primary component of treatment, offered alone or as part of multimodality therapy to more than 3/4 of head and neck cancer patients. Currently, the majority of HPV-related cancer continues to be approached with the same treatment strategies as classic HPV-negative disease. But the side effects of this treatment can not only reduce patients' ability to tolerate and complete the entire course of radiation, but many long-term survivors will develop chronic toxicities related to treatment, and that can have a very negative impact on their quality of life. When you talk to newly diagnosed patients, the option of avoiding a potentially disfiguring surgery with definitive radiotherapy or CRT may seem like an attractive option, given the perception that this will not only maintain their appearance, but also maintain the function of the organs involved. But as we continue to see in many of our survivors, organ preservation does not guarantee preservation of its function. The degree to which this function happens, especially over the long term, and particularly in the oral cavity, is only partially understood, primarily because the majority of studies don't report beyond 2 years following treatment. So my goal today is not to demonize radiation. It is representative of cure for the majority of patients, but to highlight a dimension of treatment that I think as surgeons, we need to acknowledge, and we're going to discuss the mechanisms, clinical presentation, and management in the hope that we can better recognize and manage these conditions in our patients. So to briefly review, tissue, tumor or healthy, must be in the field of irradiation to experience its effects, the good and the bad. And they're dose dependent. The higher the dose, the greater the effect. The dose absorbed by the tissue is measured in units called gray, and conventional radiotherapy is administered in daily fractions of about 2 gray per day, 5 days a week, for 6 to 7 weeks, for a total dose of 60 to 70 gray. With the advent of IMRT, or intensity modulated radiation therapy, we have increased control over the intensity and location of the beams, which has allowed for dosage modification to bystander tissues. But in most circumstances, cure comes with unavoidable collateral damage. And no tissue is completely resistant to radiation. So ultimately, it's the tolerance of healthy tissues that's going to limit the therapeutic dose. Effects to the oral cavity are among some of the most debilitating. And even with the application of things like IMRT as the standard of care, it's expected that 90 to 100% of patients with head and neck cancer will develop some degree of oral complication. And effects can be seen both during and long after treatment in virtually all of the orofacial tissues. This morning, I'll illustrate those that occur in the mucosa, salivary glands, muscles of mastication, the teeth, and the craniofacial skeleton. And these effects are classically divided into acute, which begin during treatment and last shortly thereafter, and then late or chronic, which begin at 90 days by definition and can last indefinitely. Mucositis is often the first of these to appear, and this describes the widespread oral erythema, ulceration, and soreness that develops as an early, progressive, and largely unavoidable side effect of radiation treatment. During the course of therapy, 80% of patients will develop at least grade 3 mucositis, which is marked by what you can see here are the presence of pseudomembranous ulceration and lesions. This is generally the dose-limiting toxicity for radiation and head and neck cancer, and it's the most common cause of treatment disruptions. 1/3 of patients will be unable to complete their full course of radiation due to these painful, debilitating lesions. This has obvious risks to the efficacy of their treatment. And roughly 1/4 of all patients will need a feeding tube, and nearly 3/4 of patients with mucositis of grade 3 or higher will be peg tube dependent by the end of treatment. This happens fairly quickly. Within the first week, an erythematous reaction at the tumor site is usually noticed as the first symptom, and it's either in combination with or quickly followed by this white hyperkeratinized discoloration that you can see in the top 2 photos. It occurs around the time a dose of 10 gray is accumulated. By the 3rd week, the pseudomembranes and the ulceration have developed throughout the intraoral mucosa. These often extend onto the lips and then back into the pharynx and down into the hypopharynx. These will persist for the duration of treatment. Symptoms are at their worst generally by the time a total radiation dose has reached 60 to 70 gray, and they'll continue through the first month after treatment as the mucosa reepithelializes over 2 to 4 weeks. So how does this happen? Damage occurs in a 3-phase process that's initiated by radiation-induced generation of reactive oxygen species, which result in DNA strand breaks in the basal cells of the oral mucosa. Immune cells respond to this by releasing cytokines, which exacerbate the inflammatory response and activate the pro-apoptotic pathways, resulting in death or injury to epithelial cells. Positive feedback loops then amplify the primary damage, and at this point, stem cells begin to undergo apoptosis, resulting in a loss of renewal capacity. Cellular generation can now no longer keep up with cell death, and the intraoral surfaces become denuded. Clinically, this damage is evident on exam in the form of those painful atrophic mucosal lesions and pseudomembranes, which histologically represent the inflammatory infiltrate that concentrates in the region of the basement membrane. So it's important to be able to assess, document, and convey the severity of this mucositis. Listed here are several of the available grading systems, although amongst them, there's not very much standardization or even validation. Most commonly used is across the top is the World Health Organization's classification, which is based on the clinical appearance of the lesions as they progress from erythema to ulceration, as well as the functional status, which is indicated primarily by the patient's capacity for PO intake. The second one down is the RTOG scale. It's also used clinically, and this one is reliant on our ability to judge the anatomical changes associated with oral mucositis, taking note of the size and the characteristics of the ulceration, which progress from erythema to patchy, non-contiguous lesions, and ultimately converge and become confluent, and in later stages can eventually become necrotic and bloody. And that last one is available, but it's a bit less used. It's the NCI's common terminology criteria for adverse events. It's usually used for research purposes to assess the overall picture of the collective effects of surgery, chemotherapy, and radiation. Mucositis is generally regarded as unavoidable, but there are known risk factors related to the patient, the tumor, and the treatment that may increase the severity. Non-keratinized mucosa is most susceptible. So treatment of tumors in the soft palate, floor mouth, and hypopharynx generally causes more damage than those on the dorsum of the tongue, hard palate, and the gingiva. Amongst patients, those who have poor nutritional status, unhealthy teeth, or continue to wear dentures, smoke, and drink during treatment are also at an elevated risk, as are those who experience a greater decrease in salivation and the dry mouth that goes along with treatment, who can also have exacerbated mucositis. Variations in therapy can also result in varied presentation. For example, folks who undergo concurrent chemo have wider areas of ulceration, and higher doses and more frequent sessions can result in a more rapid onset and a more intense course. Regarding treatment, there are no evidence-based measures that will totally prevent mucositis. All patients should be counseled on the appropriate measures to reduce its severity, and these should be started early. Tobacco, alcohol, and abrasive dental appliances, obturators, and dentures should be avoided to minimize irritation throughout the course of treatment. Patients should be encouraged to eat despite decreased appetite, and their weight should be followed. Poor nutritional status is a major risk factor for radiation complications. And even though the early use of feeding tubes is still controversial, they're certainly mandatory for patients who can't maintain their weight throughout treatment. Maintenance of oral hygiene should also be stressed at every visit. To reduce the risk of superinfection, patients should be instructed to rinse daily with either bicarb or saline. And as painful as it is, they need to continue brushing with whatever soft brush they can tolerate. In the absence of functioning salivary glands, mechanical plaque control promotes gingival health, and it can decrease microbial colonization. Ask about pain and escalate measures as needed. In addition to anesthetics, topical mucosal coating drugs like sulcrafate can help recreate surface barriers, which offers some protection and pain relief. They don't really help in prevention, but it does soothe some of the discomfort that patients will get. And watch out for fungus. Patients frequently will need antifungal treatment for candida infections. Taste is also affected as radiation treatment, and in 1959, this was illustrated by an Irish physician. Her name was Dr. McCarthy, and she developed pharyngeal cancer, and she wrote about it, and she vividly described her own experience with dysgeusia, or taste disruption, after radiation. She called this phenomenon mouth blindness, in quotes, and she described such unpleasant taste alterations that she eventually developed lack of any incentive to maintain proper nutrition and went on to develop severe clinical depression. According to what she wrote, everything that she ate tasted like a plate of charcoal biscuits. I've never eaten charcoal biscuits, but you can imagine how horrible that must be with anything that you used to enjoy. And all patients experience some element of altered taste beginning early on in treatment. And most often this starts within the first 2 weeks, and it can happen with exposure to as little as 4 gray. We know that the tongue has receptors for sweet, sour, salty, and bitter, and they are all affected. But interestingly, bitter and salty appear to be the most affected. Anecdotally, many patients report that those two are the first to go and ultimately the last to come back. And you'll see this most prevalently at about 2 months after treatment. This is still going on. Under the microscope, histologically, a dose of 50 gray will totally eliminate the architecture of the taste buds, which clinically you can see in the form of that very smooth, kind of glossy tongue. This is compounded again by salivary changes. The thick, viscous saliva that patients develop also forms a physical barrier to the thermal and mechanical stimulation of taste buds. And this absence of a wetting medium reduces the ability of chemoreceptors to accept stimuli from the foods and liquids that we eat, which not only results in the failure of any taste response, but it also reduces input to the salivary center feedback pathway in the brain, which further decreases salivation and creates an ongoing exacerbated cycle. Like all radiation effects, these changes are not only dependent on the inclusion of the taste buds in the field, but on the dose that they receive. It's been shown repeatedly that half of patients consistently report a subjective inability to taste after accumulation of 20 to 30 gray. And with the accumulation of 50 to 65 gray, 50% of patients will continue to have taste dysfunction at 5 years post-treatment. On the right of your screen is a graph from one of the longer studies that has been conducted. It's old, it was published in 1982, but they found that 40% of patients still had objective taste loss as far out as 7 years after treatment. Some recovery may be observed within a few months following treatment in some patients, but total recovery is rarely achieved. And this is important because lack of taste reduces the drive to eat, and that can result in anorexia, weight loss, and can ultimately lead to malnutrition. What can you do about it? Patients can be counseled to chew foods longer, to allow more time for the soluble particles that are responsible for flavor to come in contact with whatever residually functioning taste receptors they may still have. And with the exception of sinonasal and skull-based radiation, olfaction has been reported to be less frequently affected. So instructing patients on smelling food or gravitating toward food with more intense smell profiles can increase pleasure and has been shown to stimulate the appetite. And finally, small trials and anecdotal evidence point to supplementation with zinc having some promising effects on taste dysfunction reduction, but it's never been proven in a large randomized study. Moving on, the dramatic effect you can see in these photos is the result of direct damage to salivary glands, resulting in salivary hypofunction and a condition called xerostomia. This is by far the most prevalent side effect noted in patients treated with radiation, and it's a direct contributor to the development of multiple health problems. It's also consistently reported as a major cause of decreased quality of life following treatment. Xerostomia can be defined either objectively, measured as a reduction in salivary output to 0.1 milliliters per minute, which has only become symptomatic when that reflects a reduction to less than 25% of any patient's baseline. And outside of research, these numbers aren't really measured clinically, as it isn't practical to do so. And most often it's a subjective diagnosis, either by the observing clinician or by the patient themselves. There are a number of scales that have been developed for the purposes of reporting, documentation, and tracking, but they're all long, fairly cumbersome, and use is very inconsistent among clinicians. Furthermore, the majority of research shows that there's very weak correlation amongst these scores that the scales produce, any objective measurements of salivary flow that can be performed, and the patient's subjective complaints and difficulties. What patients will present with, and most often complain of, are the development of this thick, it's a rope-like saliva. You can almost pick it out of their mouth with your fingers. They all show up carrying around water bottles, but they'll tell you that the mouth dryness they have is typically not resolved even by drinking water. And this causes discomfort at best, but it's often described as pain or even a persistent burning sensation that can complicate eating, causes difficulty swallowing, and even talking. Like mucositis, it happens fast. Tenderness and swelling of the glands can start within hours of treatment on day one. And there's a steep and rapid reduction of salivary flow that will ultimately result in a 50 to 60% decrease over the first 3 days. By the final week of treatment, salivary flow diminishes to an average of 20% of baseline in most patients. And over the first year and a half, some recovery is possible, but after that, xerostomia generally develops into an irreversible and lifelong problem. And the mechanism behind the vulnerability of the salivary glands, it's a little bit non-classical and somewhat surprising. The acinar cells that make up the glands are highly differentiated cells. And unlike the epithelial cells of the oral mucosa, they're almost non-cycling and such. They would be expected to not be so readily radiosensitive. So how does it happen? The process here has been shown to occur via two distinct mechanisms. Initially, irradiated cells don't disappear, but they experience a disruption in membrane signaling, which compromises their ability to react to neural secretion stimuli. This results in hampered water excretion after the first few treatment sessions. Production of amylase is not affected, and the result is a concentrated saliva that becomes very thick and sticky. This graph notes the rapid decrease of salivary flow rate early on, while the concentration of amylase undergoes a brief increase, but the population of acinar cells remains stable. As an accumulated dose increases, the classical cell kill effect of radiation does result in a reduction of acinar cells, while damage to the extraglandular, neural, vascular, and connective tissue reduces the functioning of those cells that remain. Here we are at 2 to 8 months out, and we can see that while acinar cells can make some recovery, their function never returns to 100%. And this chronically diminished production of saliva causes a syndrome of debilitating secondary effects, including increased dental cavity formation, higher rates of acute gingivitis, difficulty with speaking, impaired taste, rampant intraoral fungal infections, and neuropathic pain symptoms in the tongue. Again, these symptoms are long-term. 60 to 90% of patients will still experience some disability at and beyond 3 years after the radiation is stopped. These long-term changes attributed to hyposalivation are multifactorial. There's a resultant decreased plaque clearance and a shift in the oral microflora, which creates an environment conducive to the development of dental caries. In addition to occurring far more rapidly than in a non-irradiated patient, the pattern of decay is more aggressive. It involves the incisors, the cusp tips, and the cervical areas. These lesions begin as a diffuse demineralization that eventually encircle the entire tooth and cause it to break off at the gingival margin. In those teeth that remain, you'll often see these permanent black lesions at the crowns of irradiated teeth that are there for life. Alterations in the intraoral soft tissues also leads to chronic mucosal inflammation as opposed to the acute mucositis. And this persistently dry oral mucosa leads to fissures and open lesions, which can reduce resistance to painful bacterial infections in locations other than the teeth. It also leads to increased friction, which makes wearing dentures difficult and uncomfortable for most people. And the difficulty with speech that happens in the acute phase ultimately ends up being long-lasting. Even years after radiation, many patients still report difficulty with enunciation and diminished intelligibility. With regard to eating, challenges to bolus formation, mastication, and swallowing cause dysphagia that can be so severe, many patients make permanent changes to their diet. And they often gravitate towards softer and frequently carbohydrate-based foods that place them at an increased risk of malnutrition. These changes give way to mucosal atrophy and an increased susceptibility to ulceration. The weakened tissue predisposes patients to development of necrosis, not just the soft tissues, but also the bones of the craniofacial skeleton. Here you can see persistent changes to the tongue, as well as the mucosa and the bone of the oral cavity. Fortunately, there's a number of measures that can be taken that have been proven to prevent or at least mitigate these effects. There are medical options in the form of cytoprotective drugs. Technically, the administration of radiation can be altered with the advent of IMRT, and surgically, it's possible to physically move functioning glands out of the radiation field. Among the cytoprotective drugs that can be administered during and after radiation that have been shown to reduce damage to the salivary glands, amifostine is the most widely studied of them. It's a thiol derivative selective for normal cells that neutralizes free radicals, theoretically protecting the nucleus and the cell membranes. Unfortunately, it also causes nausea, vomiting, and hypotension, which make it challenging to both administer and tolerate. Its efficacy was initially verified in a trial of about 300 patients with head and neck cancer, in whom at least 75% of both parotid glands were within the radiation field and hit with at least 40 gray. It was shown to reduce the incidence of grade 2 xerostomia from 57 to 34% at 1 year post-treatment, with no negative effect on disease control or survival. And based on this initial study, the American Society of Clinical Oncology recommended its use during radiation alone. The results were followed up for a full 2 years, and it showed a continued reduction in incidence as well as improvement in both the subjective and objective rates of xerostomia, and a significant improvement of quality of life in patient-reported surveys. Disease control and overall survival remained equal in both groups. Unfortunately, a separate study revealed that this reduction in incidence does not hold when chemotherapy is added to the regimen, and patients reported increased side effects with chemo on board, making it somewhat less efficacious in actual practice, given the number of our patients who receive concurrent therapy. Pilocarpine is another that I'll just briefly mention. It was the subject of an RTOG study. It's a procholinergic that can be taken orally, and in theory stimulates salivary flow in non-irradiated glands. As a procholinergic, it also causes hyperhidrosis, increased bowel and bladder motility, and flushing to the extent that compliance is a challenge for many patients. It's also contraindicated in patients with asthma, COPD, and cardiac disease, comorbidities which are shared by a majority of head and neck cancer patients, which makes its potential fairly limited. This study was done on a smaller scale, only 130 patients, and it was of shorter duration. It showed no effect on objective or subjective prevention of xerostomia or quality of life, and almost 40% of the subjects in the treatment group discontinued the drug due to its intolerable side effects. So pilocarpine really has no role in prevention. Xerostomia has also been proven to be dose dependent. In 1999, researchers at Michigan established 26 gray as the mean dose threshold, the point after which damage increases exponentially and is generally irreversible. They found that in the acute phase, glands receiving doses below 26 gray retain a substantial fraction of their pre-radiation salivary output, and at higher doses show very little or non-measurable saliva. Chronically, glands receiving doses below the threshold may make recovery over time, and glands receiving higher doses generally will not recover. Through the use of IMRT, exposure to salivary glands can be restricted through either the selective sparing of the contralateral parotid and or submandibular gland in a lateralized tumor, or by the reduction of the dose to both glands to less than 26 gray bilaterally in tumors located such that they can't both be excluded from the field. And this works. This is a graph from the PARSPORT trial. This is a landmark study proving IMRT's efficacy at reducing xerostomia, published in 2011 in The Lancet. IMRT was directly compared with conventional radiotherapy in patients treated either definitively or adjuvantly for oropharyngeal and hypopharyngeal cancer. At 1 year out, 40% of the IMRT group had grade 2 or greater xerostomia versus 74% of those treated conventionally, based both on observer and patient-reported measures, as well as objective measures of salivary flow. At 2 years out, the benefit was increased from 71 to 29%, and importantly, there was no difference in disease control. Surgically, I wanted to include this option for the sake of interest, although it has limited application. In an RTOG study that demonstrated both efficacy and reproducibility, 2 Canadian physicians, one was a head and neck surgeon and one was a radiation oncologist, found that by surgically relocating one submandibular gland to the submental space during tumor resection, they were able to spare the gland the full dose of radiation and prevent clinically relevant xerostomia in 83% of patients at 2 years from treatment. Obviously, this is not available to patients with cancer of the oral cavity or for those who have bilateral lymph node involvement in the neck. But it's an option that may be most beneficial for patients in developing countries without access to advances such as IMRT. Current options for the treatment of established xerostomia are restricted to the use of saliva substitutes or to stimulation of any residual salivary gland capacity. Pilocarpine, as well as several other procholinergics, they may help here. In addition, these patients should maintain oral hygiene with daily fluoride treatments and chlorhexidine rinses to make every effort possible to prevent the rapid destruction of their teeth. There is some evidence that acupuncture can result in significant improvement in objectively measured salivary flow rates, but oddly and unfortunately, there's no corresponding improvement in the patient's subjective quality of life scores. Trismus, or limited mouth opening. It's another not infrequently encountered but chronically debilitating effect associated with radiation to the head and neck. Variously defined as reduction in the interincisal distance to between 20 and 40 millimeters, it's considered severe when the distance is reduced to 15 millimeters or less. Unlike the acute effects we've seen so far, the onset of trismus is gradual. It's most frequently noticed in the 2nd or 3rd month following treatment. It's usually not the cause of a significant amount of pain, and speech is rarely affected. So because of its rather insidious onset, it's frequently overlooked. Patients may assume that the reduction in jaw mobility is normal, or that it'll get better on its own. Additionally, patients receiving radiation often require feeding tubes or limit their intake to mostly liquids during treatment, and may not realize the slow progressive onset until they attempt to resume taking PO with solid foods, which becomes difficult when mouth opening gets down to below 2 centimeters. Clinically, from our perspective, it's very significant in that it can require fiber optic intubation or even an awake trach in the event that they need further procedures, which is not uncommon. Trismus develops secondary to an insult to the pterygoid muscles, the masseter and the temporomandibular joint. Direct effects of radiation on the muscle result in fibrosis and subsequent contracture. Healing from the initial inflammation results in the shortening of muscle fibers, degeneration, and ultimately atrophy. And it's a progressive condition. Once it's started, damage will progress over the first year at a rate of 2 to 4% of the loss of the opening of the mouth. And if left untreated, it will become permanent. The incidence of trismus after radiation is quoted over a fairly wide range, from 5 to almost 40%. And this is likely the result of variations across studies in definition, reporting, and their method of measurement and outcome effects. As far as risk factors, the primary risk factor is the inclusion of the pterygoid muscles in the field of irradiation, especially at maximum dose. Though unlike salivary glands, there's never been a proven quantified threshold. Radiation following mandibular surgery or given with chemo also places patients at an increased risk. Management options should include prompt recognition and intervention. These are paramount to prevent or at least minimize some of the long-term consequences of trismus. At each visit, patients should have their mouth opening evaluated. One article described what you can see on the top right there is the 3-finger test that can be done over time to monitor for its development. All the studies that have been done are small, but they have looked at medications such as pentoxifylline and Botox, both of which proved to be largely ineffective. So exercise therapy is the mainstay of treatment. There are several mechanical methods that are available to treat or reverse reduction in opening, and patients themselves should be advised to perform prophylactic vertical and horizontal range of motion tests as often as possible, to the extent that they're doing them daily or even twice daily. There are some things like the TheraBite, which you see on the bottom there. It's a dynamic bite opener, and they can be given to patients where they're available, but they're often cost prohibitive. Those things range upwards of $500. So an alternative system is tongue blades. Give a patient a stack of tongue blades. It's effective, it's affordable. The only challenge is compliance. Now for the bad one. Along with tumor recurrence or second malignancy, ORN, osteoradionecrosis, is the most dreaded complication among head and neck cancer survivors. This is potentially devastating as a complication, and it can be more difficult to treat than the original tumor. Definitions vary, but it's most commonly described as an area of devitalized, irradiated bone that is exposed to the overlying mucosa or skin, persisting for 3 to 6 months in the absence of recurrent disease. At the molecular level, it amounts to a deficiency in metabolism and homeostasis attributable to radiation-induced injury. Any bone in the craniofacial skeleton is susceptible to the development of ORN, but it most frequently occurs in the mandible, especially along the premolar, molar, and retromolar trigone regions of the mandibular body. And this is multifactorial, with most often cited theories being the unilateral blood supply of each hemimandible and the lack of perforating arteries through the muscular attachments over the posterior ramus. Chewing-related trauma and the mandible being the area from which teeth are most commonly extracted as opposed to the maxilla have also been linked to the development of ORN. Clinically, patients may present with either superficial or deep involvement of the bone. Necrosis may progress slowly, or it may advance rapidly toward pathologic fracture. Patients who present may be asymptomatic, or they may complain of multiple symptoms, including chronic pain or numbness, trismus, dysphagia, pathologic fracture, or big pronounced orocutaneous fistulas and repeat or persistent infection. There's a number of theories on the pathobiologic mechanism behind this. Early descriptions back in 1970 identified a sequence of 3 contributing factors: radiation followed by trauma and ultimately infection as the inciting insult responsible for irrecoverable tissue breakdown. Was an early on theory that in the 80s was somewhat refuted by Marks, who was an oral surgeon from Miami, who implicated dysfunctional wound healing rather than infection as the leading factor. And he proposed the 3H principle of hypovascularity, hypoxia, and hypocellularity, which states that in the radiated mandible, the periosteum and overlying skin and mucosa become hyperemic, inflamed, and develop an endarteritis, which leads ultimately to hypovascularity throughout the tissue. Following that, vessel thrombosis, cell death, and necrosis ensue, leading to a hypoxic state, which ultimately leads to hypocellular tissue, marked by fibrosis of the periosteum, marrow space, and the overlying skin and mucosa, as well as the failure of osteoblasts to renew bone. Somewhat more recently, in 2004, 2 French radiation oncologists proposed what they called the fibroatrophic theory, which, like Marx and the 3H theory, cites vascular destruction and ischemia as the inciting events. In this theory, excessive proliferation of dysfunctional fibroblasts in combination with failed repopulation of osteoblasts results in bone matrix being replaced with abundant fibrous tissues that are unable to secrete collagen. The resultant tissues are fragile, and they're subject to late reactivation and persistence of inflammation in the event of even minor injury. With both theories, the end result is vulnerable tissue that's unable to maintain its homeostatic demand And in both theories, even minor trauma creates an environment beyond its capability to heal appropriately. The incidence of ORN following radiation has a bimodal distribution. Occurrences within the first 2 years most often happen in patients treated with high-dose adjuvant therapy and are attributed to the synergistic effects of surgical trauma in the setting of doses higher than 66 gray. Normal tissue breaks down spontaneously due to its chronic inability to keep up with cellular turnover and collagen synthesis. This risk peaks between 6 months and 2 years following treatment. Beyond the 2-year mark, the development of ORN is usually the result of direct trauma. This represents the majority of cases and can occur secondary to denture irritation, tooth extraction, any further surgeries, or something as simple as a biopsy. In these patients, the risk is never really eliminated because the tissue's wound healing capacity is permanently impaired. Despite the lifelong risk of ORN after radiation, 70 to 90% of the cases occur within the first 3 years. Long-term follow-up is uncommon, however, and there's very little uniformity in scoring, which causes differences in interpretation and the reported long-term rates. In this graph here, ORN is shown that it can occur decades after the completion of treatment. So the reported numbers may not really reflect the real long-term risk. Historically, the incidence has been reported over a wide range from about 5 to almost 40%, with the higher numbers occurring before modern developments in radiation like IMRT. More recent studies place the incidence somewhere between 5 and 10%. This graph is from the largest recent systematic review examining ORN from 2012. And this was a systematic review that looked at 22 randomized controlled trials and included almost 6,000 patients treated with either definitive or adjuvant XRT with a minimum follow-up of 5 years. Just 2% of patients across these studies developed osteoradionecrosis, but they did identify several key factors which were shown to elevate that risk. And these could be divided into factors related to the patient, the primary tumor, and the method of treatment. Regarding the patients, tooth extractions were by far the major risk factor. Most cases are associated with extractions, and the risk is present whether they're performed before or after radiation. ORNs also increased among patients with diseased oral cavities, unrepairable teeth due to dental caries, periodontal disease, or root lesions can cause an infection in the bone, creating an environment conducive to the progression of ORN because of the low vascular patency and the dysfunctional mechanisms of repair in irradiated tissue. Low BMI was also shown to be a risk factor. A separate study from MGH found that among irradiated patients, those who developed ORN had an average BMI of 23 or less, versus a BMI of 25 or greater in those who did not. And obviously this is clinically relevant given the negative effects on nutritional status seen in patients undergoing surgery, chemo, and XRT. ORN occurs almost exclusively in patients treated for tumors of the oral cavity and the oropharynx. The primary determinant of the extent of the mandible included in the radiation field is the location of the tumor. And so, as would be expected, it's more frequently seen in patients treated for tumors in the floor mouth, the tongue, and the retromolar trigone. Treatment of later stage tumors, direct mandible invasion, and recurrent tumors have also been shown to elevate the risk. Regarding treatment, the total accumulated dose of radiation is an independent risk factor, and most cases develop at doses greater than 60 gray. Very few cases develop at less than 50. In 1995, a study conducted in Switzerland reported on 137 patients irradiated for cancer of the oral cavity, oropharynx, and hypopharynx between 1980 and 1994, with a total target dose between 60 and 78. All 20 cases that developed did so at a mandibular dose greater than 66 gray, and no cases were seen to develop below that. In 2007, an unrelated study noted that the risk of ORN increases 11-fold with radiation doses above 66 gray. Previous surgical resection is also an independent risk factor. Reasons cited include a loss of periosteal blood supply, inadequate tissue coverage of a defect following extirpation, and a non-union of an osteotomy. So these are not absolute predictors. Not all risk factors reliably cause ORN, and not all patients who receive over 66 gray or undergo surgery develop it, just as there are cases out there that develop at lower doses and in patients who don't receive surgery. Point being that ORN is one of the more unpredictable effects of radiation, and every effort should be made toward prevention. That said, the importance of dental care and evaluation with treatment before radiation cannot be overemphasized. All patients should undergo prophylactic oral care prior to, during, and after completion of treatment. Diseased, carious, and unrestorable teeth should be extracted before XRT, and patients should receive endodontic therapy to eliminate periodontal disease and restore any viable teeth. All patients should be fitted with a custom molded tray for daily application of fluoride gel, and follow-up with a dentist should be as routine as with the surgeon and the oncologist. There is some controversy as to whether teeth should always be removed before radiation. Since 1986, the incidence of ORN after pre-irradiation extraction has been approximately the same as the incidence after post-irradiation extraction at about 3%, but ORN associated with extraction following RT often reaches a later stage and is 4 times more likely to require radical resection than when it occurs following extractions pre-treatment. Given this risk, the optimal time for extraction is 21 days prior to the initiation of treatment to allow adequate time for healing, and they should not be performed less than 2 weeks before starting treatment. In theory, IMRT may be of benefit in reducing the risk by reducing the dose to the mandible. There are no dedicated trials reporting bone toxicity that directly compare IMRT to other forms of delivery, but in 2010, there was a review that included 4 studies of IMRT, and it was demonstrated that the weighted prevalence was somewhat lower with conventional RT by about 2%. Follow-up in those studies was limited, ranging from 6 months to about 3 years. So likely there'll be additional studies needed to determine if this is clinically significant, though practically designing one of those probably would be more challenging. Management of ORN is based on the extent of bone necrosis and the severity of clinical symptoms. This is the most frequently encountered staging system. It was developed in UCLA in 2002. And stage 1 is superficial, with only cortical involvement of the exposed bones, and lesions that do not progress beyond this stage frequently resolve over time. At stage 2, the underlying medullary bone is involved, and there is the danger that these will progress to stage 3. At this point, the full thickness of the mandible is necrotic. Often, widespread disease exposes the inferior border, and it's at this stage that pathologic fractures occur. And all stage 3 lesions require surgical intervention, often with free tissue replacement of bone or soft tissue. With any case of suspected ORN, the first step is to get a biopsy. Before doing anything, you have to rule out recurrence. Then management of stage 1 and a lot of stage 2 should begin conservatively. In addition to encouraging strict compliance with oral hygiene measures, patients should be instructed to irrigate the exposed area daily with saline, sodium bicarb, and chlorhexidine. With the role of infection remaining unclear, antibiotics are commonly used, though they're not supported with any degree of convincing evidence. They rarely, if ever, offer a cure. Conservative operations may salvage tissue and should be undertaken when the condition fails to improve with medical treatment, strictly with sequestrectomy or sequential removing of non-viable tissue. Since the 1960s, hyperbaric oxygen treatment has been commonly recommended for the prevention and treatment of ORN, but to date its clinical efficacy remains unclear. Treatment consists of breathing 100% oxygen at 2.4 atmospheres in a sealed chamber for 90 minutes at a time. Mechanisms by which HBO heals have been theorized to include stimulation of angiogenesis, the induction of fibroplasia, enhanced soft tissue perfusion, and elevated resting oxygen levels. But treatment protocols are time-consuming and they're expensive. A typical protocol calls for 20 to 30 90-minute sessions at $300 to $400 per session for a total treatment course cost of somewhere between $9,000 and $12,000. There's been only one published randomized controlled trial regarding the use of HBO in the head and neck, and the results were not so favorable. It was in 2004. It was a French study of 68 patients, all of whom had clinical and radiographic evidence of ORN, and they were treated with hyperbaric oxygen. At 1 year, recovery in the HBO arm was 19%, and it was 32% in the placebo arm. The results suggested no therapeutic benefit, and the trial was actually stopped early due to an excess of poor outcomes in the HBO arm, which included failure to improve, but also seizure, stroke, and MIs. Obviously, this is only one trial and sparked controversy due to the exclusion of late-stage patients with pathologic fractures and bony erosion of the inferior border. But it's important because it's cited by many healthcare funding bodies as evidence to withhold reimbursement for the use of HBO in the treatment of ORN, which compounds the expense. When patients reach stage 3, they often have experienced pathologic fractures of the involved portion of the mandible. The only successful treatment at this point is surgical resection of all diseased tissue and reconstruction with free tissue transfer. I won't go into this anymore here, but to say it's obviously a major complication in patients who have otherwise been cured of cancer. And it illustrates my final point that cases like these really serve to illustrate the balance between surviving and truly continuing to live as a survivor, which is something that we witness frequently in our patient population. Our quest for improved disease control and survival has also yielded progressively higher rates of toxicity. As physicians, we tend to intellectualize survival with terms like disease-free and progression-free. We illustrate the effectiveness of anti-cancer therapy by citing statistics. However, studies do show that providers generally underestimate the severity of the radiation-induced effects and their impact on our patients' quality of life. The medical, psychosocial, interpersonal, financial, and as we've seen, functional consequences, not just of disease, but also of its therapies, contribute to the experience of a patient as cancer survivors and can really adversely affect their most fundamentally human activities. The consequences we've discussed here can amount to extremely difficult problems that leave patients both physically and emotionally disabled. Appropriate prevention and treatment of both early and late radiation morbidity is increasingly important because more and more patients with head and neck cancer will be cured early in their lives. As a specialty, we need to continue to recognize the needs of survivors that extend beyond the acute treatment phase. And as head and neck cancer providers, we need to be acutely aware of the functional sequelae of therapy and actively engage our colleagues across disciplines to assist with efforts in post-treatment monitoring care. So in conclusion, radiation saves patients' lives. It's necessary and effective part of head and neck cancer treatment. There's no absolute resistance to radiation, and there is a limit to the ability of normal tissues to repair the acute effects of therapy, after which patients go on to develop chronic, lifelong complications. The oral complications of radiation are complex, dynamic processes that lower quality of life and predispose patients to serious clinical disorders. These effects should be anticipated so that they may be prevented wherever possible and intervened upon early. Prior to initiating treatment, all patients should be optimized with regard to their oral health. Making this care routine, complications, both local and systemic, can be minimized during and after treatment, and measures to reduce adverse effects can be established. Moving forward in the era of shifting demographic of head and neck cancer that will lead to younger working survivors at risk of long-term functional toxicity, it will be critical to develop novel interventions to improve prevention, mitigate adverse effects, and improve quality of life in our patients. And with that, I'll wrap up. Are there any questions or concerns? And how do I see them? I don't see any questions, but if there are any, feel free. Otherwise, thanks very much for listening. I hope it was worthwhile, and thanks for having me.
Thank you very much. Good talk.
Thank you. Regarding sending you the slides, there was something in the email.
Yeah, if you wanted to send a PDF,
Is it better? Okay.
Yeah, we'll post it for them. Yeah.
Okay. I'll just send it to Sarah Lynn Buck.
Exactly. Perfect. Yeah.
All right. Great. Well, thanks very much for this. This was cool. Appreciate it.
Thank you. Great. Yeah. Glad you could be part of it.
Cool. Take care. Stay safe.
You too.
All right.